This conference will now be recorded.
Welcome, dear guests and dear friends, to the virtual hub of Online Cardiology Club. My name is Sercan Okutucu. I am an interventional cardiologist from Ankara, Turkey, and I will be moderating this online activity today. Firstly, for the ones who are new on this platform, you can write your questions or comments to the chat box, and we can ask them to our prominent speakers during the session. We have two important topics today. First is TAVI in low-risk patients, and second topic will be the surgery after TAVI. And as we know, the TAVI is increasingly being used for the younger and lower-risk patients with longer life expectancy, so these are really hot topics. But we are really fortunate to listen to these topics from two important physicians, Mohammad and Lorena. So let me introduce our first presenter, Dr. Mohammad Sarraf. As a brief introduction, Dr. Sarraf is an interventional cardiologist from Alabama, USA. He is an expert on structural heart intervention, and simply I can tell that he loves everything about cardiology. In addition to this, he is a great researcher, educator, and kind person to accept our invitation. So I will not steal more time from us from this important event. Let's begin to first presentation. Mohammed, now I will send the invitation to you for sharing the screen.
Sure. Okay, there we go. Thank you very much, Sercan, for your very nice introduction. I hope that I can have a lively conversation. So the topic of the day is TAVR in low-risk patient population. I have no relevant financial disclosures related to this talk. So as you know, TAVR has clearly exploded over the last, especially the last decade, but at least since mid-2000, the clinical trials has been coming along. So I try to focus on three goals. I'd like to have a clinical appraisal of the randomized controlled trials that we have, which are only two. It's PARTNER 3 and low-risk Medtronic valve with Evolut R and Evolut Pro, and then talk a little bit about potential complications of AVR in general, both SAVR and TAVR. In fact, in many ways, both technologies and both approaches share common complications. And lastly, a little bit about talking about how to treat and also who to treat with TAVR or SAVR. I think this is these are the three main points that I'd like to focus on, and I hope that in the next 20 minutes or so we can go through this. So this is a clinical evidence across the risk categories. Essentially, the fever of TAVR really started in late 2000. By 2011, we had the PARTNER trials published. Actually, I should have put it backwards, 1B first and then 1A, but the point here is that we started from extreme risk patients, patients who no surgeon would even bother to think about taking those patients to the OR, now down to the point that now we're talking about doing patients with low risk TAVR, to do TAVR in patients who are low risk for conventional open heart surgery. So what are the expectations in low risk patients? If TAVR wants to stand the test scientifically, it has to have excellent low-risk complications. It has to be hemodynamically at least as good as bioprosthetic valves. And I specifically say bioprosthetic valves. We can probably go into details in the Q&A as to why. And then durability is also very important. And the reason that durability is important, it's something that we do TAVR in a patient who's 88 years old, because the number of years left for that patient is very different than another patient who's 65 or 75 years of age. So here now durability becomes very critical. There is no question that everybody prefers less invasive surgeries. And this is not even related to the heart. If you talk about GI surgery or any other platform of intervention, people in general, as well as clinicians, like to go with less invasive because recovery is faster, and also the outcome seems to be consistently better for the most part. So the reason that low-risk patients studies are extremely important is that as successful as TAVR has been over the last decade, even if you include intermediate risk, roughly about 20%, 1 out of 5 patients who have severe symptomatic aortic stenosis really fall into that category. Therefore, really, the bulk of the patient population are low-risk patients, and those are the patients that are oftentimes, as you can expect, are also younger and to some degree healthier than our high-risk patients and intermediate-risk patients. Because what really drives the SCS for the most part, when you do go to the calculator, it's really the age has a huge impact on your risk profile. So I'm going to have a little bit of a deeper dive to these two famous and very well cited over the last year and a half clinical trials. Both are published in New England Journal. I'm sure that everybody's familiar with them. But as soon as these two publications came out, there was as was expected, there was a frenzy of different titles on from online to social media to newspapers, that it seems that heart valve surgery is really becoming an antiquated entity, and now we are entering into a new era. So I'd like to focus a little bit on the key features of these clinical trials. One, about the patient population, and obviously we have to discuss a little bit about the valves that have been utilized in both trials. The trial design methodologies are similar, but they are not exactly identical. So it's very important to understand the difference between the two studies, and also the primary endpoint selection. And last, about major clinical complications. I'm not going to go into too much details of the secondary outcomes and endpoints. So in terms of patient population, Partner 3 was done mainly in the US, Canada, Australia, and New Zealand. In roughly about 70 centers or so. They included about 1,000 patients with 1-year follow-up that was published in the New England Journal for the 1-year follow-up. It was considered low risk with an SCS less than 4%, and exclusion criteria, we're going to go through this because these are important. As opposed to Medtronic, which had a little bit higher number of sites because they include a number of European studies, and then it was including about 14, almost 1,500 patients, and the SCS had to be less than 3%. And this goes back to how they define intermediate risk in the TAVI trial, which was 3 to 8%. The baseline characteristics in Partner, the average age is about 73. So remember from the first Partner 1 and Partner 2 trials that the average age was about 86, 81. Now there's more than a decade difference between the two. And as you can see, roughly about 1/3 of the patients were females, and as you can see, majority of the patients are in class 1 and 2. So about 1/3 of the patients were class 3 and class 4. What's important is really the echo parameters. As you can see, the aortic valve area is about 0.8 with a mean gradient of 48, 49 with normal EF. So these patients that have been mainly randomized in Partner 3, these are really not low flow, low gradient. These are patients who have normal EF. So these are the things, these are the parameters that we have to think about when we want to include or talk about our own patients when we want to make clinical decisions. These are the baseline characteristics for Evolut. The average age is roughly about the same, 74, and female is about 36%, and the SCS is about 1.9%. And again, as you can see, vast majority of the patients were in function class 1 and 2. Only about 1/4 of the patients had class 3 and 4. Now look at the syntax score in Evolut patients. The syntax score, this is mean, is 2. And we're going to go through the exclusion criteria, but as you can see, vast majority of these patients were isolated aortic valve stenosis. So there is a difference between CAD and AS, low risk, versus isolated aortic valve, low risk. And again, if you look at the mean gradient, very consistent with what we saw in Partner 3. So the valve that was used in Partner 3 was exclusively SAPIEN SAPIEN S3, and it was transfemoral only, so there was no alternative access, as opposed to Medtronic that a very low percentage, about less than 4% of the patients had a classic core valve, but about 3/4 of the patients were Evolut R, and then about less than a quarter of the patients had Evolut Pro. For those of you who may not be quite familiar, the difference between Evolut R and Evolut Pro is that the Evolut Pro has a skirt around it, and to reduce the risk of PVL, but the size of the sheath to go through is a little bit higher. So in terms of methodology, partner 3 was as treated, but as treated, we're going to explain exactly what they mean by as treated. So neither trial was really designed from the get-go to be intention to treat analysis. Now, so if you're a purist clinical trialist, you always like to see intention to treat as opposed to as treated. Randomization was 1-to-1 to surgery, and study hypothesis was non-inferiority design with a risk difference of about 6%. Now, this is important to mention here that the partner 3 was a classic clinical trial, which is usually a frequentist, as they talk about. It basically was based on Kaplan-Meier curves and log-rank method. Everything else was pretty similar with the Medtronic trial, with the exception of Bayesian adaptive model for Medtronic, which is basically driven by posterior probability. And posterior probability is has much more sophisticated statistical analysis and formulas, and also it's much more fluid. So the trial has a little bit more tendency to change in number as they're going through the randomization. So they may add or subtract numbers, and it's a little bit more detailed oriented when it comes to clinical outcomes. This is a flow chart of the partner 3. As you can see, again, SCS less than 4%, 1-to-1 randomization. They had a sub-study of about, excuse me? Oh, I thought that someone's, okay. So they had a sub-study of about 440 patients for CT analysis to specifically look into leaflet thrombosis. And the primary endpoint, this is important to mention that there was all-cause mortality, stroke, and CV rehospitalization at 1 year post-procedure. So this is a flow chart of Medtronic trial, again, 1-to-1 randomization, and they could include alternative access, although vast majority of the patients were transfemoral anyway, and then they basically had another arm or sub-study arm of PCI and TAVR and versus CABG and SAVR. And this is again the Bayesian model. So this was the point of the reference point for non-inferiority, which had to be again 6% difference. So there was, in terms of primary endpoint, there was a non-hierarchical composite of all-cause mortality, stroke, or CV rehospitalization for at 1 year for partner 3, as we talked about, but they had multiple sensitivity analysis for secondary endpoints. So if you look at the partner 1 trial, it was very easy to pick up an endpoint because the event rate was so high that mortality, all-cause mortality, was enough to be an endpoint. When it came to partner 2A, which included intermediate risk, now they needed to have, because mortality may not have been as high, they had to add another endpoint to capture more events, or endpoints rather, not events, which included all-cause mortality or disabling stroke. And as you can imagine, in partner 3, patients are more than a decade younger. Therefore, they had to add CV rehospitalization at 1 year as well to, again, capture enough number of events in terms of making the clinical endpoints statistically significant. This is essentially what we talked about. So the key inclusion criteria is very classic, consistent with all the other partner trials, that the aortic valve area should have been less than 1, not 0.8, as it used to be in partner 1, but less than 1 with mean gradient more than 40 or jet velocity over 4. But what I'd like to focus more is exclusion criteria, and they had both clinical exclusion criteria and anatomical exclusion criteria. Anatomic, in my opinion, is what we usually have to deal more in clinical practice. So again, remember that bicuspid aortic valve was, and it didn't matter what type of bicuspid, any bicuspid aortic valve was completely excluded in these patients. Severe calcification of the aortic valve complex, mainly the LVOT calcification, was also excluded in these patients. So even if the patient had an STS of 0.9 or 1, but the LVOT was calcified, that patient would have been excluded. And again, for obvious reasons, because those patients are more likely to have PVL and eventually add the probability of death in the short and long term. And then complex CAD, but they exclude patients with a syntax score of 32 or more. So essentially, it was allowed to have lower intermediate risk score, and also low coronary takeoff, which is usually left main less than 10, was also excluded. So the key inclusion criteria with Medtronic was also very similar, and exclusion criteria was syntax score more than 20 for multivessel PCI, 22, I apologize, was excluded with again, bicuspid aortic valve, and also severe MR and severe TR were also excluded. But you can also argue the fact that if you have a severe MR or severe TR along with AS, that patient is not low risk to begin with. Anyway, so if we look at the primary endpoint, this is what really made all the bells and whistles go off, because the primary endpoint was very strongly in favor of TAVR, as you can see. And not only was it not non-inferior, but it also met the criteria for superiority with a very strong p-value of 0.001. And as you can see, the endpoints did, so the first set of numbers are at 30 days and the second set of numbers are at 1 year. So it was 5% absolute risk reduction in terms of reduction of all-cause mortality, stroke, or rehospitalization. And it actually grew to be 7% at 1 year. And it doesn't really matter how you cut and slice the data, it was consistent across the board. And when you look at all-cause mortality, it was at 30 days was 0.4 versus 1.1, but at 12 months was still absolute risk reduction was 1.5%, yet it didn't really reach statistical significance. There is a relatively, I wouldn't say a very strong trend, but there is some trend there. If you look at all stroke, again, 0.6 at 30 days versus 2.4, clearly surgery has significantly higher risk of stroke. If you recall from specifically Partner 1A and 1B trials, it was very clear that surgery was significantly better in terms of stroke. But remember, at the time, the devices that we were using were very different, and so was the fact that we were really not very familiar with the procedure as far as how we should pursue. We were not using CT scan, and we were still gaining a lot of experience. But if you look at 1 year, 1 month versus 12 months stroke, you can see that the difference is still not bad. It's about 1.9. But look at the ratio between the two. So it's almost 4 times the risk of stroke at 30 days versus about 2.5 times. So it seems that it's diluting the difference between the two. And these are important. Yet the p-value is still 0.04. And rehospitalization was also in favor of TAVR. So no matter how you look at it, it was consistently in favor of TAVR. When it comes to the primary endpoint for Medtronic, it clearly and easily met the non-inferiority, but it actually did not reach superiority. And I'm going to go through that in a second. So the major clinical outcomes with Partner, was it non-inferior? Yes. Did it meet the criteria for superiority? Yes. And in terms of everything else, all-cause mortality, it did not reach statistical significance, but again, a relatively strong trend. Stroke was less, rehospitalization was less. Death and disabling stroke was strongly in favor of TAVR. Again, you can see that everything else was pretty much consistent with Medtronic, with the exception of the fact that it did not reach superiority based on the predefined criteria that the clinical trials had already introduced in the beginning. Now, what happened with partner 3 is that one of the I don't want to say benefits of COVID-19 rather, but what happened is that because virtual ACC 2020 happened right in the middle of COVID, a lot of people might have missed this. So when you look at the 1 year to 2 year follow-up, we can see that the primary endpoint continues to be in favor of TAVR for partner 3. So this is SAPIEN valve. But when you look at the death or disabling stroke, as you can see, it was strongly in favor of TAVR, but see what happens at 2 years. At 2 years, all of that benefit that was there with a relatively strong p-value of 0.02 is washed off. Now, why is that? Why these two curves are getting closer together? And we have to dissect this a little bit. So I apologize if I have to keep moving stuff here. So if you look at stroke, stroke is not as strong at 2 years between the two. So it's very important to figure out why the rate of stroke has leveled off with CABG as opposed to TAVR that seems to have been consistently going off. And when you look at death, again, it did not reach statistical significance. And now remember, this is not CV death. This is all-cause death. So even if the patient has car accident or whatever happens, that's still considered death. But again, that trend seems to have been washed off at 2 years. So these are the causes of death. If you look at that, the numbers of events are not very high, but this is surgery. 1 patient due to heart failure, 2 are unknown. When it comes to TAVR, suicide, well, you know, if someone commits suicide, I'm not quite sure if you have to blame it on TAVR, but sepsis, that is interesting to know whether it was endocarditis or not. Cancer, which again is cancer, but cardiac arrest secondary to complications of hip surgery, 1 unknown, and then fatal intracardiac bleed secondary to fall, and also sudden cardiac death. Yet again, when you put that as an endpoint, then it's an endpoint. All-cause death is all-cause death. So what are the other complications? We already talked about enough about mortality and stroke, so I'd like to focus a little bit about PVL and conduction disturbances. PVL has really become less of an issue. It's not as bad as it used to be back in the early era of TAVR in late 2000 and even up until middle of 2014, 2015 or so. If you look at the trend, this is a slide from Dr. Thrani, it has clearly calmed down. And remember that this is moderate severe. Now, the PVL is not just as simple as moderate severe. The location of the PVL, I personally believe, is different. We've done some studies on this. We've published 1 paper, and there are more papers to come in the next, hopefully, year or so. But it is not as bad as it used to be, and it seems to us that TAVR can actually match up the level of SAVR when it comes to PVL, at least in partner 3 and with SAPIEN 3 and Evolut R and Evolut Pro. How about pacemaker? We know that pacemaker in general is a negative endpoint, and it's bad to have. At least financially, it's really bad to have, because at least in the United States, I don't know how it is in other countries, including Turkey or Brazil, but in the United States, if I do a TAVR and after the TAVR patient gets a pacemaker, the hospital doesn't get paid for the pacemaker. So the hospital loses money because of the pacemaker, because we have to pay out of the pocket of the hospital to discharge a patient with a new pacemaker. But we know that the pacemaker, at least if you believe the data at 30 days and 1 year, it seems that they are fairly comparable, although numerically it seems that in TAVR it's a little bit higher, but at 1 year it's not as strongly in favor of SAVR. But left bundle branch block, as you can imagine, you're deploying the TAVR device in LVOT, and it is certainly higher. So durability, why is it important? As I discussed early in my talk, there's a difference between a patient who gets a bioprosthetic valve versus an elderly patient. An 80-year-old male or female may have only about 7, 8, 10 years ahead of themselves, but a 65-year-old may still have another 2, 3 decades ahead of themselves. So the younger you are, the rate of valve destruction is obviously higher as well. And we know that the structural valve dysfunction, as is known as SVD, has many different mechanisms. If you have not read this paper, I highly recommend this paper to everybody. It's a remarkably detailed paper that has gone through different mechanisms, but it essentially boils down to really biochemical versus biomechanical. Biochemical usually pertains to more stenotic valve dysfunction, and biomechanical is more consistent with regurgitant valve dysfunction. So there are many reasons as to why TAVR compared to bioprosthetic TAVR may be inferior to bioprosthetic SAVR. And there are multiple papers written on this, but if you really want to think about this, it seems that it eventually boils down to crimping of the valve because it damages the tissue of the leaflet for preparation, either with balloon expandable or self-expandable. Which leads to valve damage because not only do we crimp, but we also have to go through these sheaths, and the sheath also puts some extra pressure on the leaflets. And also then the decalcification treatment of the TAVR system is not as robust as it is for bioprosthetic valves. Lastly, I want to focus a little bit about how to treat versus who to treat. If you have not reviewed this paper, I highly recommend this. This is a very nice community-based analysis of patients who have undergone aortic valve replacement and mitral valve replacement with mechanical and biologic prostheses, and basically they looked at the endpoints, and the conclusion was that in the long term, mortality benefit was associated with the mechanical prosthesis as compared with the biologic prosthesis persisted until 70 years of age among those who received mitral valve replacement and 55 years of age among those who received AVR. In other words, which is a little bit of a surprise to me. So essentially what it means is that if you get an AVR up to the age of 55, it's very reasonable. And as this is the common practice to place a mechanical valve for the patients. And I don't know if you have any surgeons in our friends here online, but if you look at any mechanical valve compared to any bioprosthetic valve, their hemodynamics are consistent and always better. This was a little bit of a surprise to me, that I thought that if there should be any benefit, I expected that aortic valve should have had a longer longevity. I thought that maybe aortic valve should have been better up to even 65 or 70 years of age. And this is a mitral valve that again shows that up to 70 years of age, it seems that mortality is lower in patients who get mechanical mitral valve. Now, I don't want anybody to read too much into this. Remember that this is not a randomized controlled trial. We can argue that patients who received mechanical valves were also healthier. That's why they ended up living longer. And this is a very nice algorithm of Dr. Sorgensen. I don't want you to focus too much on the algorithm. It's basically common sense, but he's nicely put it into a flow chart. So when we get a severe symptomatic AS, I think CT scan is very important. Even if your intention is to go for a surgical approach to begin with, I think CT scan gives you a different perspective, a different dimension that you might not have been able to achieve by echocardiography. So in conclusion, I think both trials are very well executed. They have selected a very interesting patient population, yet we have to remember that we have to, if you want to offer TAVR to anyone with a low risk, we have to stay in the confines of the inclusion and exclusion criteria of the studies. Patient selection, as always, to me, is the most important feature and possibly the most difficult part of clinical decision making, not just in cardiology, I think for any specialty or subspecialty. I really wish that FDA, and this is my personal opinion, obviously, everybody has his or her own view, I believe, but I wish that the FDA had waited for at least 5 years until we see what happens to these Kaplan-Meier curves, and then they issued a TAVR indication for low risk. Association of other valvular heart disease and complex CAD is very important. So if you have a patient who has a left main and is diabetic, or has 3-vessel disease and is diabetic and also happens to have AS, make sure that you think twice before you offer them TAVR. And be careful to say TAVR for low-risk patients for all, because there are many other dimensions that are oftentimes missed. Thank you very much. This is my email. I specifically placed it here in case that anybody has questions later, and this is my personal cell phone. Feel free to call me or text me anytime. Thank you very much for your attention, and I'm happy to answer any questions if there is any time left. It says I finished right at 1:30.
Thanks, Mohammed, for the excellent presentation and clear messages. I have some questions to you. One of my questions will be, as you know, the many recent evidence about the 4D CT studies about the reduced leaflet motion and the hypoattenuating leaflet thickening. What do you think about the clinical impact of them? What do you think? Do they differ from the transcatheter heart valves or surgical bioprosthesis, or this will be a future problem?
Yeah, a very good question. I didn't even bother to go through that slice of the data. So there is no question that halt is higher in TAVR. Even in partner 3 was significantly higher, and 100% of patients who had halt also had reduced leaflet motion. Not everybody had higher gradient, although those who had halt had higher risk of having higher gradient. And we're still learning about this. Now, one of the things that I didn't mention, I made it look like that they only randomized 1,000 patients, but in reality, I think they randomized close to 1,200 because they had to get to that CT sub-study. So they continued randomizing patients after partner 3 was basically published, but it has many consequences. One of the most important of which is that we know that halt is usually, not always, but usually due to, especially early on, due to thrombosis. And as you saw, there is an ongoing trend of stroke with TAVR that we did not observe with SAVR. So is it something that can potentially lead to stroke? The data doesn't suggest that, but I wouldn't be surprised if this is something that we find. The other thing that is very important is that when the surgeon goes to place a bioprosthetic valve, they put the orientation of the leaflets exactly as close to as natural orientation of the leaflets. In TAVR, we don't know which direction we're placing them. Now, we think that the aortic valve is a circle, but it's not. In fact, it's a triangle, it's an equilateral triangle. And the orientation of the leaflets are important because it also has an impact on the coronary flow. So based on the vortex formation in the sinus of Valsalva, that changes the coronary flow. So the other thing is this neosinuses that is formed. Neosinuses, again, for those who might not be familiar, is the area that is basically manufactured. This area is between the calcified native leaflet and the stent and the new TAVR leaflet. So this area now, if you can see my hand, this V-shaped area becomes a nidus for thrombus formation. So I think, and a lot of people have focused now whether we should do anticoagulation, whether we should do a DOACs. At least the only trial that I'm aware of is Galileo, which showed that if anything, actually NOACs were worse compared to aspirin. But I think people are trying to simplify things that, okay, thrombus, therefore I have to give the anticoagulation. Maybe the answer is not anticoagulation. Maybe the answer is that we have to focus on which orientation we place the TAVR. So I think there is still a lot more to learn, and I hope that the CT sub-study will continue to teach us a lot more lessons that we'd like to practice in our daily life.
Yeah, thank you, Mohammed. And another question, as you showed in your slides about there is some erosion in the benefits of TAVI in the second year of follow-up in partner 3. And what do you forecast about the future? I mean, there is plan to follow up for 10 years. And what will happen? It's just an idea.
Well, great point. So that's exactly why I said that I wish that FDA had waited 5 years at least. Now, I wouldn't say 10 years, but at the end, 5 years is something that for many drugs and many other devices, we wait for about 4.5, 5 years until they give a green light as an indication. Well, I'm not a surgeon in full disclosure, so surgeons have the luxury to say, I don't care, but if the FDA takes the indication off, I'm still going to operate. I can operate. So I hope that the curves flatten, but we don't know. If you recall, when we were in Zurich, we had a panel discussion over this, and I think I was one of the few ones who believe that it's very risky. You really have to be very brave to say that we're ready to have indication for low-risk TAVR. I never believed it. I thought that it was too premature, and unfortunately, 2-year data didn't seem that confident. So I hope that by year 3, the curves level off. But we live in real world. We don't live in hope is not a strategy. Let me put it this way. We have to just wait and see what the results show us.
Yeah, thank you. And a little question outside of this presentation. And can you explain your heart team to us? I mean, what do you think about heart team, and what is ideal heart team in your opinion?
Well, I think ideal heart team should be part of it is this bizarre structure of healthcare system in the United States, which to me is very fraudulent. This is the best way I can put it. But right now I'm in charge of 3 hospitals. So 2 hospitals I have been able to synchronize. A 3rd hospital hasn't come on board yet. But the way that we do it is that all the surgeons in both hospitals and all the structuralists and imagers in the hospitals, we used to go to one hospital. Now, because of COVID, we are all having this virtual meeting now. We basically analyze every single detail of the patient. We basically go through H&P. We have a slide presentation that usually one of the coordinators provide, and then we sometimes if there's a question, especially for mitral more than AS, but if there's a question, for example, about gradient or whether the patient needs a PCI before TAVR, we usually review the data together about a week or 2 weeks before, sometimes a month before. It depends on how busy we are, and then we have a very clear vision as far as what we do. So basically on that day, we make the decision as far as what we're going to do in the cath lab or in the OR.
Thank you very much. Thank you very much, Mohammad. Now we will pass to our second topic, which is surgery after TAVI. And as we know, emergent surgery after TAVI is an uncommon situation, but it can still happen. So the heart team should be ready in case of emergent surgery. Now I am really glad to introduce Dr. Lorena Montes. Of course, first of all, she is a good operator and well-respected cardiovascular surgeon in Colombia and Latin America, and also in our group. She is an active researcher, educator, she has a music band, and really many things. So, dear friends, I would like to thank to Dr. Montes again for kindly accepting our invitation. Let's start to our second presentation. And dear Lorena, stage is yours, and let's begin.
Thank you. So first of all, I want to thank you, Serkan, for this invitation. And also, and I work in Cali in 2 hospitals, university hospitals. So after Mohammad just talked to us about the low risk in TAVI, I will take it further to surgery after TAVI. So the agenda we're going through is to review the emergent surgery TAVI and to review the late surgery after TAVI. So what are we talking about? When it's a life-threatening cardiac complication during TAVI, we go emergent cardiac surgery. And when it's a long-term failed TAVI, we do a planned cardiac surgery. The Part 2 has definitions as an emergent cardiac surgery is defined as any conversion to open sternotomy during the TAVI procedure secondary to procedure-related complications. And also the mortality, immediate procedural mortality, was defined as the death before 72 hours after TAVI. In 2012, the guidelines of the ESC and the ACTS estimated that approximately 1 to 2% of TAVI patients require emergent cardiac surgery for life-threatening complications. But this has been going down rapidly because of the rapid technological development, the refinement of the TAVI devices, the wire guides are better pre-procedural imaging, and increasing of the operator's experience. The European Registry on Emergent Cardiac Surgery during TAVI is all we need to know about emergent cardiac surgery after TAVI. So between 2013 and 2016, 27,760 patients in 79 different centers. I'm sorry, they told me the presentation is not being seen. It's okay? Serkan?
It's okay, Lorena.
Okay, thank you. So from 2013 to 2016, 27,760 patients in 79 different centers were followed in a registry, only transfemoral access. In the overall 212 patients, it's 0.76% of the 27,760 patients underwent emergent cardiac surgery secondary to TAVI complications. So as the volume of TAVI growth almost duplicates in 2 years, the complications that needed emergent cardiac surgery went down and stabilized in the last years on 0.7. This is because of the technological advances and the operator's experience that we already talked. So these were the baseline characteristics of the patients, almost 70% females. Of course, they were patients that were very sick. They had 23% more than 20 of ERA score 1. And the different type of complications that needed emergent cardiac surgery. So the first one was the left ventricular perforation by guide wire. It was the more prevalent. Then annular rupture, valve embolization or migration, aortic dissection, right ventricular perforation by the pacemaker wire, pericardial tamponade, coronary obstruction, left ventricular perforation by the delivery system, paravalvular leak, and a lot of other complications that were just anecdotal. The temporal evolution of these complications have been shown, especially the ones that are associated to greatest mortality, like left ventricular perforation and the annular rupture, that they've been going down with time because of the technological advances and the operator's experience. These were the types of device that they used. So they used everything that was in the market. So balloon expandable, transcatheter, self-expanding, and the mechanical expandable lotus valve. And then they did an analysis by subgroups to see if we could associate the complications to the type of valve. Something was kind of found, but it wasn't very strong. So the annular rupture actually was associated with the balloon expandable valves, but the embolization was graded in the self-expandable and the mechanically expanded valves. But this is all declining because, and expected to decline because of the dedicated guide wires and the technology that it's better imaging before the procedures, for example. Aortic dissection was associated with the mechanically expanded valve. And the mortality was very, very high, even though you survived the procedure. So the mortality in at 72 hours, immediately procedural mortality was very high. And even if you survive the procedure and the emergent cardiac surgery and you went alive from the hospital, the mortality at 1 year was 78.2%. And this mortality was associated with annular rupture was the one that had the biggest mortality, also coronary obstruction, aortic dissection, and left ventricular perforation. But the right ventricular perforation and the pericardial tamponade had a really high mortality too. So I will take you to 2 clinical cases. These cases were done at the Hospital Clínico San Carlos from Madrid. and they were kind to let them borrow them to me. I was present in both cases, so I can speak freely about them. So this is an 83-year-old female who had a symptomatic severe aortic stenosis. The Euroscore was 13.8% and the Euroscore 2 3.95% because she had an ejection fraction, the ventricular ejection fraction of 38%. So at the heart team, we always went transfemoral first. So we decided transfemoral access and implanted a coral valve 26. But after the implantation, the patient turned hypotensive and the ETE showed a high implant and a small flap in the aorta with severe pericardial effusion. So the patient was taken to emergent cardiac surgery like 5 floors upper. And this is what we found when we opened the patient. Of course, she had pericardial tamponade. We just drained that, and we could see the struts of the core valve going through the wall of the aorta. As if you can see, that I'm showing with this. Okay, so we went to CPB, and then we opened the aorta. We had to open in the middle of the frame because it was too high, and put some cold nitinol to take it out. But as you can see, the aorta was damaged, so we had to perform a biological substitution, valve substitution, and also to put supracoronary diaphragm tube to replace the aorta. This is a second case, 78-year-old female, symptomatic severe aortic stenosis. She had an Euroscore of 7% and an Euroscore 2 of 1.86%, but this was a really fragile woman. So we decided to go transfemoral access and to implant a core valve 26. After the implantation, the valve migrated towards the left ventricle. So a second core valve 26 valve was implanted, but the patient just got very hypotensive. The TE showed a severe MR with interference of the interior mitral leaflet, and we took her to emergent cardiac surgery. So we went on CPB and we opened the aorta, this time a little upper than the frame, and this is what we saw. So we had to put a snare with a suture around the frame to take it out because it was pretty low. The first one was pretty low, so it was difficult to take them out. You can see here with the arrows, this is the native valve going through the wall. With some nitinol, we could, and the snares, we could just take it out. And this is what you were seeing before here. These leaflets that you are seeing here were from the upper one. So maybe I can show from this upper one. So imagine this was very, very low. This is why it was interference with the mitral leaflet. But both of the two patients went home and remained well after that. We implanted a biological prosthesis, and we didn't need to do anything to the aorta. This is emergent surgery. So my key messages for this part is, for this first part, is that emergent surgery after TAVI is an uncommon situation, but still occur. That is why we need to have a heart team, a real team, that should be prepared for emergent surgery always. Now we're going to review the late surgery after TAVI. So why is this important? So the TAVI volume is being increasingly, really rapidly expanded, the field of TAVI, over the last decade, with more than 500,000 procedures in more than 70 countries. And the volume is growing by 40% annually. So at the right, you can see the German registry. It's now duplicate for like 3 years, just duplicate. And also is going, it's expanding, the indications are expanding, so you can see that the patients are going to TAVI younger and also with an error score that is less risky. So Mohammad just spoke about all of this, and this is what we have to think. So we are putting TAVI in patients that are at low risk, sometimes going further with younger patients, and we need to think about long-term complications like palpebral leak, thrombosis, prosthesis mismatch, endocarditis, or structural valve deterioration. And why? Because after this happens, one of these complications, maybe you can put a TAVI valve involved, but usually you have to do a surgical explantation. And if you can review the data in the literature, that is very low. What we all are concurring is that the clinical impact of surgical implantation, well, it's lacking, but it's probably more complicated. So if we go to literature, we have 11 case reports from 2008 to today, and we have 2 observational studies and a registry that is ongoing. So let's try to explain a little bit of this. So would it be technically more difficult? Well, probably, because as surgeons, we need to see if we have a high implant or a tall stent valve, we need to see where to clamp, where to do the aortotomy. Maybe we can have problems in the root, like in the arrow in this picture. We have an endocarditis in here that is complicated with a pseudoaneurysm of the root. Also, the endothelization of the aorta and the damage that it can cause to it when we take out the prosthesis. And of course, these patients sometimes, if they are just not low risk, but they have another problems, but we will have to deal with these problems, like this porcelain aorta. So let's speak about the aortic cross-clamp in the aortotomy. How difficult could this be? So there's one study that the Milano group published recently about the CT scan theoretical analysis to see the aortic cross-clamp and where to open after the implant. So they reviewed 170 CTs acquired after TAVI. These were patients that just needed a CT for any reason, and they just took advantage of it. And these were high stent prostheses, only high stent prostheses, so no Sapien, no Lotus. The mean distance, they measured the mean distance between the innominate artery and the top of the stent, and it was 45 millimeters. They didn't have any patient with less than 20 millimeters. This is very, very important because it's kind of what we as surgeons need to put the clamp. Okay, so the other thing was the mean distance. They measured the mean distance between the senator junction and the site of where they could have a margin free to perform an aortotomy. So above the top of the stent. And they had 22 millimeters at mean distance. This was actually acquired from 2008 to 2017. And they conclude that you can safely clamp the aorta in all the cases that they reviewed, but the aortotomy had to be higher than normally. And this causes an issue to surgeons because if you have to address problems in the root, this will be very uncomfortable. Also, to put a valve in the annulus will be also uncomfortable and technically difficult. So this is something to have in mind. And they recommend to have a CT before any explantation of TAVR. What about the endothelization? So why do we need this? Because we have no idea yet of the natural history of the interaction of the TAVR and the integration of these prostheses to the aorta. So Van Kesteren et al. Performed 72 autopsies post-TAVI. 9 patients were more than 30 days, and they saw an intimal tissue overgrow after 6 weeks after the implantation. This is kind of what it looked like at 6 weeks. So if you can see, it's the top of the stent is always endothelization first. Novel et al. Also performed 4 autopsies post-TAVI, and they had a range of days from all the patients. So 3 days was the last one, and 350 days was the one that went further. So they did their own history, natural history of endothelization. So they are describing like early fibrin deposits, then local inflammatory response, and then late neointimal tissue develops covering the frame struts. Like you can see in this image, it's pretty clear. So at the bottom, you can see endothelization at the left ventricle outflow tract, but you don't see any endothelization, which is pretty good actually, in the sinus of Valsalva. Why is this? Because it's not opposition to the aorta wall, so it won't endothelize. But in the upper, just in the top of the stent, it will endothelize. This is another example. And they did, of course, the histological pathology cuts and seeing the neointimal tissue. So we need to have clinical implications, but this is the first study that is published, and it was really recently published, not even yet in the published Journal of Thoracic and Cardiovascular Surgery. But this is the Michigan group that took 1,442 consecutive TAVR patients from 2011 to 2019. They did 15 explantations, which is 1%, and they took also 2 explantations from outside. So these were the preoperative patient characteristics. So 7 to 3 years, just 30% of porcelain aorta, pretty much what a TAVI just normally has. But previous cardiac surgery was in 47.1% of the patients, and also 41.2% had valve-in-valve procedure already. This is important because the STS PROM was of 3.5 in the original TAVI. But we will see that it would completely change. So the clinical indications for valve replacement were paravalvular leak with the first prevalence, and it was at 96 days mean that they had to have surgery in these patients. Structural valve degeneration at 3.3 years medium to do the explantation, and then intraoperative valve migration, intraoperative coronary obstruction, prosthetic valve endocarditis, and bridge to definitive open procedure. This bridge to definite open procedure is a special patient that had I lost the word in English, sorry, a stroke, and he couldn't be taken to surgery, to normal surgery. So he was taken to a TAVI as a bridge to the definitive open procedure because it was a very young patient actually. And he also had a root enlargement, so he needed more surgery than that. The operative data, so now the STS PROM was 9.9, and with TAVR, the device was explanted from 13 core valves or Evolut Pro, and 4 Sapiens. Also the days, well, you can see if we just divide less than a year and more than a year. So they had to do aortic surgery and 2 root replacement. The endarterectomy was in chronic patients was 100% done, and they had to do a root patch repair. This is the patient with the root patch repair that had a very high calcification, severe calcification, as you can see here. And also when the TAVI was explanted, well, all these non-coronary sinus was damaged, so they have to put a patch to repair it. So what about the outcomes? Well, the first thing is we are seeing all the time more explanted TAVIs as they actually saw. As you can see, it duplicates and triplicates in just 2 years. The in-hospital mortality was 11.8, which is pretty high, but 20% when it was a patient that had a late explant. All the patients with late explant had renal failure, developed renal failure, and also the days that they need in the ICU stayed were a lot longer than a normal procedure and when it was less than a year old. Why is probably this? Well, probably because of the endothelization. The endothelization after a year is pretty severe, so to take out the valve will be more complicated and also maybe needed of another procedures like an aorta replacement or a root replacement. Finally, the comparison with the box plots of the original TAVR and the TAVR explant of the STS-PROM showed a very high STS-PROM after when the patient had to have the TAVR explant compared to the original TAVR. So this is a patient that is a lot far more complicated than before. And the survival at 3 years was 68%. So what about the registry? Well, as I just told you, the literature actually, we are lacking a lot of literature because we were not concerned about these patients, just implant, and not what is going to happen with these patients after. So now that everything is expanding, the indications are expanding, we are concerned. As surgeons, we are more concerned. So that's why there is this registry that is ongoing, that it's been ongoing by Dr. Babhat, Dr. Tang, and Dr. Denti. Dr. Tang actually let me use the data, so nothing is published, just the protocol I will speak. So the study objective is a multi-center retrospective study that will aim to report the mechanism and timing of transcatheter valve failure, timing and type of surgery performed on these patients, and also the clinical outcomes. And the outcomes are in hospital, 30-day clinical and echocardiographic outcomes, and long-term clinical and echocardiographic outcomes that will be reported by the BARC and the standard surgical definitions. Now I want to show you this clinical case that it's already published in the Annals of Thoracic Surgery, but I think it's pretty clear with some very good images. This case was performed at the Hospital Universitario Central de Asturias. This is in Oviedo, in Spain. And Dr. Silva, that was one of my professors when I was training, was the one who operated this patient. So he just gave me the images. So I want to share it with you. So this is a 59-year-old male that has severe renal dysfunction and dialysis because of hypertension. He had severe symptomatic aortic stenosis, and when he was 54 years old, he was, they told him to have surgery, but he rejected the surgery, so the heart team decided to put a core valve in him. 5 years later, he was admitted with acute pulmonary edema. He had multiple echocardiograms in the follow-up, and everything was okay. But this time, the ETT showed a structural valve degeneration with critical aortic stenosis. And so they decided to explant the TAVI and do a conventional aortic valve replacement with a mechanical prosthesis this time. So this is a video. This patient is already in CPB, and you can see the technique to take out the TAVI. So it's been 5 years. It's completely endothelized in this upper part. So the important thing here is to search for a plan, to search for valvular, not valvular, but for to search where to go to do the endarterectomy. Just not to cut through the aorta, but to search a place to go in. So with this spatula, they are just going slowly. And when they get to the sinotubular, to the sinus of Valsalva, they will have more space because it's not there and they have no epithelialization, as you can see here. So after detaching the valve from all the endothelialization and the aorta, you can just pull gently through the valve, doing this endarterectomy. And you can see the endarterectomy plane in there. With this spatula, you can just go further and go doing your plane. Then you have to assess when you take out the valve, you have to assess the aorta and how damaged it is, because these can go, as in this case, as small damage, through a really, really big damage that could need even a patch or a replacement of the root or of the ascending aorta. Then you can, here you can see, sorry, here you can see how the aorta was kind of damaged, but it wasn't that damaged to change it. And this is the explanted valve. So you can see here in the blue arrow that there is endothelialization of the upper part of the stent, and also there is endothelialization of the lower part of the stent in the outflow tract of the ventricular, of the left ventricle. This is just when they open to see also the endothelialization. You can see it better from here. And of course, how it was calcified. So the key messages for this are: late surgery after TAVI is more difficult, but it's feasible. And always think about clinical implication of this difficulty. Is it going to be more morbid? Would it increase the mortality? This has to be thought because nowadays we can offer the patient either TAVI or a valve replacement, open valve replacement. But we have to give all the information, because one of the things that are specific in every case report in the study published by Michigan group is that none of the patients thought that they needed a surgical removal of this, or that would be needed, they would be needing surgery in time. Even though they were, some of them were young, some of them could actually have it. Like when you as a surgeon explain bioprosthetic valve, you always emphasize in the possibility of a reoperation. But these patients all were thinking that the valve in valve was possible, and maybe the valve in valve not that easy in some patients, and they will need explanation. So we need to think about mortality and morbidity. And we are hoping the registry will come out soon and give us more information. Thank you. This is my email also, and we are open for discussion.
Thank you very much, Lorena. It was an excellent presentation, nice cases, and really good videos. We enjoy a lot. There is one question from the audience, from our dear friend Luis Contreras. Dr. Montes, what is your opinion with on-site cardiac surgery support now that TAVR has become minimalistic?
Sorry, repeat the question, because right now
What's your opinion about on-site cardiac surgery, as we know that TAVR become more minimalistic nowadays?
More minimalistic as a TAVR, you mean?
Yeah. What do you think about minimalistic TAVR? I mean,
now I'm pretty much for it. You know, if let's say, let's be clear. I'm not against the technology at all. I think this technology is here to stay, and this is a good technology that needs improvements. I am 100% agree with Mohammad that maybe we are going further very fast, faster than we should, and faster than the studies and the data is coming out. So maybe this goes, this is not going very well for the patients actually. And of course, not for the surgeons that have to explain the valves. But if the technology can provide us minimalistic and patients without anesthesia and patients going home earlier, well, that's great. That's great because this is an improvement for the patient. But I think we have to be cautious because I think we are running before even learning to walk. And that I think it's going to have us explanting a lot of valves and having problems in the future, not that far away.
thank you. I want to ask one question. What do you think about ECMO and other temporary support in addition to emergent cardiac surgery in TAVR complications?
It depends if it's emergent cardiac surgery and you need something because the patient is crashing. Of course, you need to keep the patient alive as you can, as far as you can. Now, if you put an ECMO in a patient that is that has an annular rupture, and what you need is to go to the OR as quickly as you can. It's the only way to just try to save the life of the patient. But of course, you can use ECMO for any of the complications of the TAVR actually.
Mohammad, do you want to ask something or comment?
No, I just wanted to second what Lorena just mentioned. I think we have to take our time, and I think we've had this conversation on the CAS WhatsApp group that the whole premise of doing research, either clinical or basic science, it doesn't matter, is to ask whether our hypothesis is correct or not. We don't do research to prove our hypotheses. If we want to say, well, let's say that in 5 years TAVR turns out to be worse than SAVR, okay? Then what do you want to tell your patients? And I think this is something that FDA has jumped the gun too quickly, because first of all, I already know that a lot of people, at least in the state that I'm living in Alabama, of all the places, even when the patients are low risk, they just call it intermediate and they just do it. Okay, so people have already, the indication creep has already happened. So we have to be very careful how we analyze the data. We have to be very objective and look at the data the way it is, not the way that we want it to be. So I personally think that TAVR I personally don't do any low-risk TAVRs. Just in the last 4 or 5 months, ever since 6 months since I joined here, I think I've sent at least 7 or 8 patients to our surgeons, all of whom were very low risk, all of whom I knew that I could do it today and discharge tomorrow morning. But why would I want to? And one particular case was actually a bicuspid that would not even meet the criteria anyway. But I think the reason that I wanted to go a little bit too much into the details of the clinical trials is to tell everybody that, you know, I always used to tell the fellows and residents that we don't treat numbers, we don't treat pictures, we treat patients. Who cares what the STS number is? You can have a patient with an STS of 1.5%, but has cirrhosis with platelets of 25,000. Do you really think that the patient is low risk? Or you might have a patient whose STS may be 8.2%, but is an otherwise a very vibrant 82-year-old gentleman who's still mowing the lawn he happens to have a high STS because he has diabetes and takes insulin, and also is 82 years old male. That by itself, that 82 years old is going to add a lot to your STS, but has heavy calcification in the LVOT. I think maybe that patient is better off with a good surgeon to do a good, especially if it's an isolated AVR, to do a good operation and offers the patient what's best for the patient. That's the value of heart team. I mean, if the value of heart team is just to sit around the table and just agreeing with each other that everybody should go to TAVR, I'm not quite sure if it's a good heart team. So I think eventually, if Partner 3 and Evolut or Medtronic low-risk trials continue to stay on the same curve and the same difference, probably in the next decade or so, I think 75% of all the AVRs would be TAVR, but I can never see a day in which SAVR will completely go away, the same way that I never see a day in which CABG will ever go away. I think these are complementary techniques, and I don't see them as being competitive to each other. I see them as being complementary to each other. That's how I look at that. At least this is my opinion. I'm not saying that I'm right. This is my opinion.
I completely agree. And actually, I wanted to say something because I just read the question from Luis, and he is actually referring about this minimal approach, because some centers that are performing TAVI are advocating to not have cardiac surgery in the field, which for me is kind of crazy, because even though it's minimalistic, I think that the whole point of this is to be a team, to have a heart team. And if you don't have your cardiac surgeon, then what team is that? If you have any complication, even though it's minimalistic, you will have to intubate the patient, go on ECMO, and call a surgeon to come to you and help you. No, the surgeon should be involved in it. And that's what we are advocating for, surgeons to actually completely learn all the techniques, because we should just do like a crossover between us and become a team. It's what we should do from the beginning. It will improve our practice. It will improve our results. Well, that's pretty much what I have to say about it. And there's another.
The one thing that we have advantage in the United States is that from the very beginning, before it even came to commercialization, they mandated that the surgeon and the cardiologist must be together for the entire pathway, not just for the procedure. They have to see the patient in clinic together. They have to have the heart team. And if we want to get paid, the surgeon and the cardiologist must be in the room together at the time of the procedure. Otherwise, the case doesn't get paid. So I think from that standpoint, we're lucky in the United States that they pushed us to work together. And actually, it turned out to be a very positive outcome for not just for us, for the patients more than anybody else.
Of course. There's a question from Gustavo Licurgo that I wanted to actually answer. It's a surgical question. So Edwards has been advertising a surgical valve that is dedicated to valve in valve. So actually, this is the last Edwards valve. They released it in Latin America just just like a year ago. And it's actually very good valve with a different tissue that it's supposed to be more durable. It's called Resilia. The valve is called Inspirit Resilia, and it has like some features that are preparing us for the future and for this team we are talking about. So first of all, it doesn't need to be watched out. It's just ready to use, which is great for surgeons because it will improve the time. We don't spend time watching the valve or anything. And they have this tissue is supposed to be a lot more durable, so it'll be great too. because we could think in bioprosthesis in a young patient, and it's also prepared to have a valve involved in it. So it has a portion of the valve that can fracture really easily, just not like the other one that is just a stand frame completely done like a ring, but this one actually has a part that will break. It's prepared for it. So that's a very, very nice valve that we actually are having right now in the market. So let's hope it works actually with the tissue, I mean, the durability.
There is one question from audience, Dr. Mehriban Iskender asking, it will be fascinating if you share your own experience about low-risk patients who undergone TAVR. Do you get any benefits or not in such group of patients? Or maybe, do you want to answer, Mohammad? I mean, what should be the ideal? What I understood is what should be the ideal patient that we should do TAVR for low-risk patients?
Oh, okay, fair enough. I think, so the one thing that I didn't touch upon is that when we say low risk, we have to say low risk in who. If you're talking to me about a low risk 68-year-old, I'd rather not do a TAVR on that patient. But if you give me a 78-year-old and 80-year-old who's low risk, to me, that's a good low risk. So it's someone who doesn't have, and by the way, this is not my opinion. These are the exclusion criteria in the trials, both trials, that they should not have severe LVOT calcification. They should not have significant PAD. Although if they have significant PAD, then they are not low risk in the first place. They are at least intermediate risk. So that adds to complexity of the case. But if you're talking like truly low risk, meaning that STS less than 3, if you want to use Medtronic 4, if you want to use Sapien, I think it has to have good anatomy. Ideally, they should not have, certainly not left main or severe 3-vessel disease. If you want to go by Sapien criteria, the STS should have, I'm sorry, the syntax score should have been less than 32, for Medtronic less than 22. So essentially low risk PCI, if anything, and then those are good patients. Lastly, if they have any other valvular, let's say that someone has moderate TR, I'm not saying severe, let's say moderate TR, or let's say mild TR with tricuspid dilatation and severe AS, that's also a patient that, unless they have very high STS or they have other comorbidities, I'd rather do a surgery instead of TAVR, because even if I do TAVR in such a patient, that dilatation of the tricuspid valve is going to eventually turn out to be a moderate severe TR and eventually end up with a RV dysfunction. While it takes a surgeon about 10 minutes to do a quick tricuspid ring placement, right, Lorena? 10, 15, 20 minutes. I mean, it's not a very complex procedure. It's not like mitral valve repair. And then you can actually change the outcome of the patient, because one of the things, the reason that I bring up TR is that it's one of those things that everybody thinks that we're talking quite enough about it, but clearly it's not enough. I see a lot of patients who just call TR mild based on color Doppler, but they don't pay attention to the size of the tricuspid annulus. And what really is a driver of RV dysfunction, and it's not just about TAVR, for in anything in cardiovascular disease, it's the tricuspid dilatation and tricuspid annular size. So once you have tricuspid dilatation, even if your TR is mild, eventually this patient is going to end up with RV dysfunction. Now, these are the patients that, especially if the patient is not going for a redo, especially if it's a virgin chest, it doesn't add that much to mortality, unlike what people believe. So when you hear that mortality of patients who go for isolated TR is 25%, 20%, those are all redo TRs. If you look at not primary TR, but if you look at the virgin chest, first operation tricuspid surgery, it's not as bad in terms of outcomes. So basically, I would follow whatever the clinical trial said. I look at the inclusion exclusion criteria and whatever they said. the patient has met the criteria, then I think it's reasonable to go ahead and do a TAVR. That's my opinion.
And I want to ask one little question to Lorena. What do you think about the hybrid lab?
I think
Did you have
it's
hybrid lab in Spain?
what?
Did you have the hybrid lab in Spain when you were there?
No. When I was there, there was not hybrid lab. Actually, my first hybrid lab that I saw was in Berlin and then in Leipzig, and it was great. But then I came back to Colombia, and I don't have it. I don't have it yet, but I think it's something is worth to spend, because it's really easy, the procedure, you know, and if you have any complication, you can treat it just there.
Yeah, especially after seeing your videos, I think it's a must. Huh? and also there are many peripheral vascular problems. What do you think? Yes, it's not much like before, but it's reduced.
Yes,
but
it's still, but it has been reduced a lot. The vascular problems, because of the size of the devices, of the size, everything has been going down very, very quick, actually. So, well, it's still some very low percentage of vascular problem, but it's not high at all, not very representative. You can even, it's weird that someone that performs TAVI, transfemoral TAVI, actually uses an open arterectomy, you know. Normally, it's just the puncture and the closure devices.
Yeah.
I think the market actually has been improving a lot in these things that were a big issue in 2013, 2012. It was a big issue. It was too big. The catheter was very big, and you could have ruptures of the iliac or the femoral artery. But right now, it's weird. And actually, also because of the imaging techniques, you can analyze everything before, and everybody has learned of the experience. So it's slow now.
Yeah, thank you very much, Lorena. Now we have 30 minutes over time. Any questions? So we have come to the end of the session, but let's try something new for the ones that can open their cameras. If they open, let's 5 of us will present themselves to us so we can know each other better. Yeah. So let's start from Alper. Alper, can you present yourself, us?
Yes, of course. Firstly, I would like to thank you, dear Lorena and dear Mohammad, for their nice presentations. My name is Alper. I'm interventionist cardiologist from Turkey, and I'm very proud of being with you. And also, I have a special interest in heart failure patients, especially who needed the device therapy. So this online education is also very attractive for all of us. I'm very glad to be with my colleagues all over the world. And I would like to thank you, Dr. Okutucu, for this enjoyable virtual hub. I'm very happy to be with you. Thank you so much.
Thank you very much. And our dear friend, Luis Contreras, can you introduce yourself?
Hi, my name is Luis Alvarez. I'm from Mexico City. I'm also an interventional cardiologist with interest in vascular and structural heart procedures. So I have known Serkan, Lorena, Mohammad, and the rest of the bunch from the last year, and it's been an interesting experience about getting to interact with people from around the world and to participate in these activities. So hi everybody in Turkey.
You already presented yourself to us, but maybe the ones that didn't watch our last session.
I'm just waiting for the final with all the photos, with all the hands. So I'm Esteban Martins from Rio de Janeiro, Brazil, and I'm very glad to be here and to attend this meeting. And Mohammad, Lorena, Serjan, you did a very great job. So compliments for that. I'm very happy with you.
Thank you all. Thank you, dear friends. You made us happy with your attendance. So let's close the session. See you soon, dear friends.
Bye.
Bye bye.
See you, everybody.